Dr. Vivekanandan is a young, dynamic cataract surgeon with a very great future, as was earlier alluded by Ramurthy. Besides his forays into performing cataract surgeries in big numbers, what needs a special mention is how he turned around the Arvind eye care systems in Tirupur, Udmalpet and Pondicherry and stepped beyond to capacity building and surgical training of hospitals in Cambodia, Ethiopia and Tanzania, and has brought a difference. And today, Dr. Vivekanand will be crisply dwelling on the challenges that face us with a Morgagnian cataract. On to you, Dr. Vivek.
Good evening, everybody. Good evening. I would like to thank Ramurthy sir, Chitra madam and Shreya for this opportunity. So today I'll be talking about phacoemulsification in Morgagnian cataracts. So Morgagnian cataract, we don't need any introduction. We have a lot of liquid cortex, very hard nucleus. When we attempt phacoemulsification, the problem is we're going to have a lot of endothelial damage, chances of posterior capsular rupture, and nucleus displacement into the vitreous can be common in these type of patients. So it's very important that we give a proper preoperative evaluation and preoperative medication like mannitol or oral glycerol or Diamox to these patients so that we keep the vitreous condensed during surgery. And this type of cataract has become very common in the current scenario, in the current COVID time that we're all going through. We see a lot of these patients and also worse cases than this, post-Morgagnian ALC rupture, nucleus in the anterior chamber, nucleus embedded within the pupillary margin. We are seeing almost 1 or 2 cases every week like this here. So how do we go about when we see cases like this? A normal Morgagnian cataract, yes, we can attempt a phacoemulsification. Whereas cases like this, it's always better to do a small incision cataract surgery. So this is a video of a Morgagnian cataract phacoemulsification. Rhexis was done, the cortical fluid was drained, direct chop was done, vertical chop was done and made into 4 quadrants. And each quadrant was emulsified gently. A lot of viscoelastic, dispersive viscoelastic was used to prevent the endothelial damage and it was done repeatedly. But this does not happen always, from the beginning, when you're doing cortex drainage, if you're a little more aggressive, what can happen like this video, you end up having an Argentina flag sign. So it's very important that you drain the cortex very slowly. You do not inject the fluid, the jet of BSS into the bag forcefully. You have to do it very gently. At the same time, you should not collapse the anterior chamber because collapsing can also cause an Argentina flag sign. The other problem we are going to face while we are operating on such a nucleus is the nucleus is very mobile. There is no traction between the epinucleus and the nuclear material. So there is no epinucleus. So this is what happens. The nucleus is slipping away. So this can cause zonular dialysis or it can further cause damage to the already pre-existing zonular weakness. And last but not least, when we are going to operate on these patients, we're definitely going to encounter, chances of encountering a posterior capsular rent is higher because there is no protection to the posterior capsule because of the absence of epinucleus and cortex. In that case, it's always better to switch to a superior section, do a sclerocorneal tunnel, gently remove the fragments before they fall down, do an anterior vitrectomy, and place a 3-piece foldable or a PMMA lens in the sulcus. But these are the common things that we are going to encounter when we are doing a Morgagnian cataract. But there are other ways to prevent this kind of complications, prevent this. So the main problem is the bag is well extended, has become swollen in these patients. So gently drain the fluid from the bag. So once you drain the fluid, the nucleus sinks to the posterior capsule totally. The normal width of the nucleus would be around 4 millimeter. In this case, it could be more. So you gently do a Rhexis. A forceps is always preferred than a cystitome because since there is an absence of epinucleus and cortex, using cystitome will be very difficult. So here what we do is we levitate the nucleus gently within the bag and the IOL is injected into the bag. So while injecting, you can see the nucleus is being gently pulled and placed over the IOL. So once this part is done, there is enough PC protection. The other important thing is the IOL acts as a zonular, it gives a little bit support to the already existing zonular weakness. and then a direct chop is performed. You can either do you can use a sharp chopper, and you can create a small trench till the middle part of the nucleus and gently crack it. And the entire procedure can be done within the bag. The most important thing is to use a lot of dispersive viscoelastic. I prefer using viscoat. I use it a couple of times during surgery. And the theory behind this is, you have a lot of milky cortex in the bag. Once we drain, the nucleus is settled down. So even if we place an IOL in the bag gently, it's not going to overcrowd the nucleus. It is as good as a regular phacoemulsification, because the liquid cortex which has come out is being replaced by the IOL, which is roughly around 0.83 millimeters. So there's another improvisation which I've been doing for the past 1 year, where it's the same, where the liquid cortex is being drained. Using a forceps, the rhexis is being done. The nucleus is gently tilted within the bag, bimanually with 2 instruments, and the IOL is being gently injected into the bag. So gently make sure that it goes inside the bag, and then the nucleus is pushed back inside. So when you are going to do phacoemulsification on harder cataracts like this, there are chances of further endothelial damage. How hard, how much ever dispersive viscoelastic we are going to use, we can damage the endothelium pretty seriously. And most important thing is, having the first crack in a Morgagnian cataract is very, very hard. So I've been trying with the MyLoop, and there is a little bit of learning curve with the MyLoop, but it is a little bit easier once we practice. So once the first crack is achieved, you can, when you have 2 heminuclei, it is easier to do phacoemulsification, break it further, or you can use the MyLoop still to make it into 4 quadrants. The main important thing to keep constantly watching is to keep your anterior chamber filled with. So keeping the anterior chamber filled with viscoelastic, make sure if you think the AC is collapsing or a little bit of swelling is there, do not hesitate, always inject some viscoat or any other dispersive viscoelastic so that you protect the endothelium. And we have the posterior chamber intraocular lens which protects the PC. So this is the diagrammatic representation. And gently phacoemulsification is performed. So you don't have the problem of doing a chop or anything, because the MyLoop helps in re-chopping your hard nucleus. So the take-home points is proper preoperative assessment. Since in these hard times we see a lot of these cases, and even more worst case scenarios like the pictures I show, it's very important to do a preoperative assessment. Any preoperative medication like mannitol or Diamox or Orvisurol, whichever keeps the vitreous condensed and keeps the surgeon comfortable. And before planning on what surgery to do, always an intraoperative assessment, because in some of these cases you can see that the entire bag complex is floating in the anterior vitreous phase. The moment you take a phaco probe inside, it's going to sink. So preoperative assessment after filling the anterior chamber with viscoelastic is very important. So make a small nick, drain the cortical fluid gently, fill the bag and the anterior chamber with viscoelastic, and complete your access with a forceps. Do not try to do a divide and conquer or a stop and chop, because it's going to exert more pressure on the bag complex and you're going to cause a zonular dialysis. So preferably direct chop. You can use a sharp chopper for vertical chop, or you can use a blunt chopper and do a very careful horizontal chop, because there is no epinucleus or cortex. You have to be a little careful. And the most important point, liberal use of viscoelastic, dispersive viscoelastic repeatedly, and stabilizing the bag. You can, with practice, you can do the piggybacking of the IOL. If the bag is very weak after rhexis, you can place a CTR and then complete your surgery. And always be prepared, always be prepared for conversion. There is a very, very high chance that you're going to have a posterior capsular tear in these kind of patients. So always be prepared. If you prefer having a superior rectus anchored, do it before surgery. And then you can always convert to a small incision cataract surgery. Thank you very much.
Thank you so much, Vivek. I mean, excellent array of videos which shows your mastery and confidence over the surgical process. Let me just share it with the panelists. I mean, just to encourage you in the sense that we are streaming live on the web link as well as the YouTube and the FaceTime, and there's a huge audience. I think I would also encourage the people attending to send in their questions if they are on the web link. We'll try to take them up as many as possible. Suhas, would you like to comment on this beautiful presentation?
Yeah. First, I would like to really congratulate him. He's shown a beautiful film. He has tried to cover all the possible, angles from which you look at this Morgagnian cataract. And well, I have personal experience with me, and for many others, knee loop is probably not used it. But I'm very glad that he also does that, scaffolding of lens into the back, because these lenses, after most of the cortical, liquefaction, they're so small, and doing conventional phaco in these cases is extremely difficult because the lens, the nucleus is extremely wide. The technique that he has shown is good, but a slight change what I do is I prefer to do a fake, bevel down phaco. Once you have your lens, single piece lens in the back, and your filled dispersive viscoelastic around, I go with my phaco tip with bevel down. And with bevel down, you can grab that nucleus because it's relatively smaller than the usual nucleus, and then you can easily do a quick chop that you really wish to do. But otherwise, another point that he said I really agree with is that you have to assess the capsular bag and its strength. Will very often long-standing Morgagnians probably will have loose zernules. And if you suspect that the eye has got a loose zernular capsular bag, in spite of doing a very uneventful surgery, it will be quite good that you inject endocapsular ring, and because you already have put a lens, but with a single piece lens in such back, you can always put an endocapsular ring to further stabilize the back strength. But otherwise, I think I agree with him. Most of the points he's covered, and my congratulations. He's a young guy and he's doing extremely well. Thank you.
I also felt the videos were amazing, Dr. Vivek, especially using the IOL scaffold, which makes so much sense. But in a nucleus which is small and floating, don't you think using a MyLoop would be a big challenge? You've done it very well, but do you have any special message to give as to how to use it in these eyes where the bag itself is going to be quite lax?
Using the MyLoop is a little bit easier compared to doing it on a regular phacoemulsification. Because on a regular phacoemulsification, it's very difficult to identify the edges of the nuclear margin. We want the MyLoop to travel along the surface of the nucleus so that we do not go into the sulcus, damage the bag or something. It's a little bit easier. Only thing is we have to have the bag and the anterior chamber viscoelastic. Even while positioning the MyLoop, we might lose a lot of viscoelastic. In that case, it's better to refill, use your other hand to inject viscose through the paracentesis and then continue with it. The only problem is when we are going to kind of snare with the MyLoop, the nucleus is going to tilt inferiorly in the opposite direction. It's going to lift on the opposite direction and it's going to get depressed on the subincisional area. So for that, it is better to use a second instrument, a chopper or a spatula, so that you keep the nucleus intact. You don't let the nucleus wobble too much into the back. So this is the only indication of MyLoop that I use. For other regular cases, I don't really prefer using it. I find it a little bit more advantageous because I reduce a lot of phaco energy and I kind of reduce the endothelial damage also when we try this.
Gaurav, I know that most points have been covered, but you deal with many cataracts like this. So your inputs, I was especially fascinated about putting a lens inside. We've been using this IOL scaffold in other situations with the whole total cataract there, lens, nucleus there, and putting a lens. Your comments?
Yeah, I think, amazing presentation, first of all, and I will carry on that. But, and also very good points from Dr. Haldipurkar, sir. But I think this new technique which has come up over the last year or two where you put in the lens for these Morgagnian cataracts as a scaffold is amazing. But a couple of additional points that I would like to add. I like to size my rexis a little smaller than my usual rexis in these cases. Otherwise, sometimes the the fragments or the nucleus, because it's a very small nucleus. It can tend to kind of come out and, becomes a bit of a problem. So to keep all the stuff inside, it's easier to just have slightly smaller, not very much smaller, because it's a hard cataract. The second thing is that when embedding, as Dr. Haldipurkar said, bevel down. But another additional thing is that if you try to engage, if you're doing a direct chop and you try to engage the nucleus bang in the middle as you would normally do, it becomes very, very difficult. So what I do is I stabilize it with a chopper, move it away in the back, and try to catch it from the equator of the nucleus, because it's much easier to engage. You should have a good viscoelastic cushion all around it, as Dr. Vivek already said, the viscode. That's what I would use, because that helps stabilize the nucleus. And then stabilizing it with a chopper, I would move it to the side and try to actually, embed from somewhere close to the equator, because there it holds much easier for the initial embed. And once you have one crack and you have broken it into two pieces, then it becomes easier, because then you have the whole, edge of the cracked nucleus to catch hold of and make four pieces. And then, usually it's much easier once. But I would also caution about the last piece. When you're removing the last piece, you have no cortical cushion. It's very important to switch to lower parameters at that point, and become very careful to ensure that you don't have a PC which is quickly coming up and touching your phaco handpiece, because you tend to use higher parameters for these Morgagnian cataracts. You need higher vacuum, you probably need higher energy, because you're dealing with a hard cataract or a hard nucleus, so you can get searched for that last fragment. These are a few additional things. Rest, of course, I think everything was covered so well.
I think it's very, very
I think,
Yes,
Ram, I have a few points
quickly, yes.
which I would like to comment. Of course, very nice presentation and surgeries. One thing is, while doing the rexes, many of these cases have a lot of capsular fibrosis. And then when you're doing your rexes with your forceps, there is a tendency, if there is fibrosis, the zonules are weak and you pull on it, then you can have a zonular dissection. So I like to use a bimanual technique where I support the capsule with a second instrument like a spatula or so. So there's some amount of counter traction, and the traction is not completely related to the zonules. That is one thing. Then the viscoelastic of choice for me would be Helon 5, because here there is no epinucleus. So you want to create an artificial kind of epinucleus, something that stays there. And I find that Helon 5 is better than Viscode or the other viscoelastics, the viscoadaptive viscoelastics. It fills the bag. And the technique I like, of course, the MyLoop is a great tool. I have a lot of videos. I've used it for such cataracts and it works well. But if you want to do a direct chop, then I like to tilt the nucleus so that the pole is standing up like a salute, and then bury from the anterior pole to the posterior pole with a counter pressure with a chopper, because these are very mobile nucleus, and then you can easily split it. So this is some of the variations, but otherwise excellent presentation.
I think excellent points. I think one of the challenges is the very fragile capsular bag, and that the hard nucleus is spinning around there, and all of you are given
the only word of caution is when you have an IUL and you're doing phaco and using your chopper, there is a chance that you can damage the optic, you can scratch the optic. So you should be very careful about that, and probably put in more viscoelastic and do an anterior chamber phaco, because if the nucleus is very close to the IUL and then you're trying to chop, there is a chance, especially if you're not very experienced with this.
Any quick comment, Professor Chi?
I think that for me, this is an indication for either Zepto or capsule laser, because I often encounter fibrotic capsules. And when I do a bimanual capsule rexes, I really use two micro instruments. So a Utrada micro forceps, and the other one's a micrograsper to provide counterforce to do a bimanual capsule rexes.
I'm surprised you mentioned Zepto and capsule laser and left-out femto laser. Do you prefer those to this? I mean, I think any of these intumescent cataracts is one of the challenges to get a good rexes, and I'm very happy with LRCS.
Well, in my publication, I actually felt that Morgagnian cataracts are contraindication for femto, because the moment you hit the laser on the capsule, you get all the milk coming out and it blocks the rest of the laser. And your anterior capsule actually drops in the level. So it bypasses the treatment. And so usually these are like half done. Whereas if you have suction, like a Zepto, it will actually suck onto your capsule and will complete that cut, even if it's liquid. And it will actually, I've seen David Chang's video, it's amazing. It just sucks out all the liquid and you're left with the nucleus alone. Yeah.
Great. It's interesting, it's just that in our experience, I've also had occasions when, the entire capsule has got disrupted while doing a femto, because the sudden gush of fluid that comes out. but most often it is you get a nice template. It may not be a free-floating rhexis, but you use that, and with a rhexis forceps you are able to delineate. But obviously an interesting observation.